Welcome to Oncology Morning Commute, shifting treatment sequences in the relapsed or refractory diffuse large B-cell lymphoma landscape. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from ADC Therapeutics America, Incorporated. In the final episode of our series, Dr. Paolo Cami and Dr. Juan Alderuccio discuss the changing treatment landscape for diffuse large B-cell lymphoma. With more and more options, the paradigm is shifting, and that's the good news. Information about the faculty and disclosures can be found at morningcommutepodcast.com/BCell3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Cami is on staff in the Department of Hematology and Oncology at the Cleveland Clinic in Cleveland, Ohio. Dr. Alderuccio is an associate professor in the Department of Medicine at the Sylvester Comprehensive Cancer Center in Miami, Florida. I am your host, Candace Hoffman. Dr. Cami will begin our discussion.
Dr. Alderuccio, welcome back. In our last podcast, we discussed antibody-drug conjugate agents and other agents for relapsed diffuse large B-cell lymphoma. As we get increasing amounts of data on these therapies, our treatment landscape is changing. We'll talk about that. So I think probably the biggest change that we're expecting to see, we already had the big change at the beginning introduction of CAR-Ts in the early relapse and refractory setting. I think that's probably one of the major landscape changes that we've seen in the last 10 years for diffuse large B-cell lymphoma, maybe longer. And I think the question now is, when or whether, right, I think it's expected to see an approval for the combination of polatuzumab and R-CHP for the frontline treatment of diffuse large B-cell lymphoma. How do you see these changes in treatment of diffuse large B-cell lymphoma for the frontline, as well as for your subsequent choices of treatment? How will that affect your trial design, et cetera?
Yeah, thank you. I think if a patient was treated in the frontline setting with polatuzumab based regimen, I would probably don't use it again in the second line setting. I think in that, if the choice will be a clinical trial, and if a clinical trial will not be available also CAR-T as we discussed. But if the patient is not eligible for transplant, CAR-T, or a clinical trial, I think the two drugs that probably I would consider tafasitamab len, that was approved in this setting, and eventually loncastuximab, if that has been approved after 2 lines of therapy. There are several phase 3 clinical trials that are currently testing this drug in combination with other agents. For example, a trial comparing tafasitamab len plus a bispecific versus tafasitamab lenalidomide, and also the LORIS-5 clinical trial that is comparing the efficacy of loncastuximab versus R-CHP. So I think this trial have the potential to move some of these agents to earlier phases of the treatment lines. However, also there are many other agents that may become approved in the short term, specifically the bispecifics. I think the bispecific will change how we approach and how we treat these patients in the very close near future.
I'm in complete agreement. I think that you have to choose with whatever the patient got before. I think that I don't think I was expecting to see this much change in such a short time.
Yeah.
And it's been fun and a challenge to see how rapidly we're probably going to be changing our frontline therapy. Whether we do it for every patient. My suspicion is that this, after 20 years of not necessarily failed phase 3 trials, I think every phase 3 trial that was done in the last 20 years that wasn't able to beat R-CHOP wasn't a failure, but is really kind of a movement towards progress to say, A, we actually need better drugs because some of the drugs are probably not as active. But B, we need better trial design to be able to find out how we can truly impact the patients with diffuse large B-cell lymphoma that may get the biggest benefit from a more intense or more targeted therapy, like with the addition of polatuzumab. But I also think that if B, it takes 1,000 patients to demonstrate you can beat the frontline standard, right? You cannot do it with a 200-patient trial. And C, it's probably not the last one. I think that we're not going to have 20 years of polar CHP as the only standard. We're going to start seeing a barrage of different trials that are hopefully going to be positive.
Yeah, all of these agents are also currently tested in frontline setting. Frontline using loncastuximab, using tafasitamab, lenalidomide, and using bispecifics. So as single agent or as in combination with CHOP immunochemotherapy backbone. So yeah, it's going to change very fast, and we just learned about bispecific at ASH 2020. Yeah, so it's just only 2 years ago.
Very rapid. I think that's one of the things that it's kind of moving in a much higher speed. I think I stole this phrase from somebody, but I think we were living in, or at least in diffuse large B-cell lymphoma, living in a linear world, right? We went CHOP, ICE, transplant, and then whatever you have, to now having more than one. So going to a matrix, right? You have a multitude of different things, and how you choose, that's kind of the next thing. How do you choose your front line? It's probably a subject for a different podcast, right? But it'll be interesting to see how do we get to select this, and then if we treat patients with one of these new targeted agents, right? I think we already touched it a little bit. What are we going to do with the patient who gets polatuzumab in front line? We're probably not going to do subsequent line. But what happens when the front line also includes tafasitamab? Are you going to do the subsequent or loncastuximab, right? And the problem, for example, I think the particular issue that has loncastuximab is that it targets CD19, which is a target that is shared with CAR Ts, right? I think that although we think CD19 loss is not a common event, we're always worried about that.
Yeah, I think that's a valid concern about the use of in early phases of loncastuximab because of the potential cure of CAR T cells. So that may be an issue. And the problem is we don't have good biomarkers to predict outcome in these diseases. There's some emerging data using PET-CT biomarkers like metabolic tumor volume, but we don't have the truth that we don't have good and validated and clinical and routine practice biomarkers that will tell us what are the chances of a patient to respond to one specific therapy over the other. That's the big challenge, and that's what is creating this confusion.
I agree. I think that that's probably the next step for therapeutics is going to be kind of the development in the diagnostics and the predictive diagnostic tests, so that we can select treatments based on what will benefit the patient most, particularly when we have not just one novel agent, but several novel agents up to the front line. And I think maybe for Lonca, right, or for other drugs that target CD19 like tafasitamab, the emergence of non-anti-CD19 CARs that are being tested, either CD20 targeting that are already being tested in trials or other targets, or off-the-shelf CAR Ts, whether that will change whether you can use Lonca up front and without concerns because you're going to target a different surface marker. So I think it's definitely a changing treatment where you're actually, or a treatment landscape where you're actually not just changing front line, you're changing your second line, and with the new approvals of both CARs moving up to the front, to the earlier phases, to the initial relapse, it kind of opens up the third line, right? And I think that that's where whether we can actually improve on CARs on the second line, have other agents, it's just becoming definitely more complicated. I'm not complaining about it, right? A lot of people will think that we're complaining, but it's like it's definitely an era of lots of abundance.
a good problem. And actually, patients that they used to have a very poor prognosis, that are the patients that progress after CAR T, bispecific has been shown very excellent responses in this hard to treat population. A single agent, or for example, the combination of mosunetuzumab with polatuzumab, they show very good response in this setting. So I think the bispecific will definitely change the landscape once approved. The question is where they will fit in the long term. Is more in the front line or in the relapse setting?
I agree. I think diving a little bit more into that, how do you think we'll manage the relapse of after CAR? I mean, I think we have a significant number of patients are relapsed early after a CAR. Patients not responding or having problems in the first year. How do you manage them now? How do you manage them? How do you expect to be able to manage them the next maybe 2 to 5 years?
So right now, I try to enroll those patients in mosunetuzumab polatuzumab trial. And I think also epcoritamab, a single agent, has been shown also very good responses in this population. I think we will need to see how long those responses last. We don't have long-term follow-up data in this with bispecifics. So I think that's the question right now, how long those patients will achieve the responses. Do we need to consolidate with something else afterwards? Probably no, but we don't know. That's my approach right now. And how we will treat, I think the beauty of the bispecific is that are off-the-shelf therapies, and we'll be able to be providing at any clinic without the complexity of the academic centers. So then I'm sure that at some point we will start to have trials comparing these compounds with cellular products.
I think it's interesting in part how the introduction of these new treatments, just not only ADCs that are coming, bispecifics, CAR Ts that are coming, how they're starting to open maybe different areas of research, right? I think before we were thinking, what is your salvage therapy? What's your third line regimen? Now I think we haven't really explored with significant focus, well, what is the right bridging regimen, right? Or should we, like we talked I think in our first podcast, should we be exploring, is there a debulking strategy prior to collection? Should we be giving an immune stimulant like a PD-1, lenalidomide, or something else prior to collecting T cells? I think a lot of us see preclinical data suggesting that combination with targeted agents may make sense, but I don't think it's an area that we've fully explored kind of in a large scale in clinical trials. And I think that the question is, do we have adjuvants that are better for CAR T, so like maintenance post CAR T, or is something that you can actually rescue CAR T afterwards? So I mean, we talked about how the landscape changes how you treat it, but I think for clinical researchers, it's just are there new questions to start to ask?
Yeah, patient that is progressing after frontline, we don't know that the chances of a patient with primary refractory disease and progression of disease to frontline therapy, those patients may not respond well to CAR T. We know that elevated LDH at the time of collection has been associated with, is a marker of worse outcome. Yeah. So maybe bispecific may fit in this setting and can be a good bridge therapy for subsequent CAR T.
Yeah, or consolidation with something else. Or I think that the ZUMA-12 data, although I think it has some caveats, right, knowing that it's just positive PET, not necessarily fully refractory, but at least from what seems to have been the case is the majority of patients were truly refractory to R-CHOP, which is the kind of patient that we tend to think, that I usually say that's the kind of patient that really keeps me awake at night. And I think that at least the T cell subpopulations and the high response rates suggest that those patients may be more prone to respond well to immunotherapies, right? Whether that use T cells. And I think a bispecific would make a lot of sense there. Although whether it's in combination with chemotherapy, maybe you use something that is less toxic for T cells than cyclophosphamide, for example. I think we also haven't explored, I think it's initial validation of the studies, how flu-cy was important for CAR T cell persistence, but are the doses correct? Are we using too little? I think maybe is that one of the reasons why tisagenlecleucel performed a little bit worse? Maybe one of them. So I think we haven't. There's a lot of areas that I think we haven't really explored as clinical researchers in lymphoma that we could start asking questions about how we can improve it. We haven't even talked about sequencing, right? I think that sequencing different drugs can also be maybe more active and in the long term and achieve long-term disease control.
Yeah, the issue with sequencing is once you start a trial, when you finish the trial, probably that information may be all in this setting. Yeah. Because correct. With so many new, so what will be the frontline, the standard of care in 2 or 3 years? So we don't know if it will continue to be R-CHOP, maybe polatuzumab with CHP, or maybe with another compound. So I think that's the challenge.
How do you think will be the sequence? So think of it, this a year from now, Polar-CHOP is selected and you're treating somebody with Polar-CHOP. You see somebody, you give them Polarix, and then how you think that will change your sequence? How would you use, we'll talk about Lonca, how will you use Tafa? Do you think will change a lot how you selected it like you did before?
Yeah, I think we probably I will not use polatuzumab and bendamustine rituximab again. So I will select. The problem is you don't want, if the patient will go in for CAR T, there are some concerns to targeting CD19. So I will probably don't use loncastuximab or tafasitamab before CAR T because of that concern. I agree with you that the downregulation of CD19 is not the main mechanism of resistance for CAR T. However, as this is a potentially curable therapy, you don't want to eventually take that risk. So that's a good question. I think probably bispecifics will fit very well in that setting as bridge therapy for CAR T. The question that will come later on, if we still need to do CAR T, if we start to see mature data with bispecific, that patients, that survival data remains to be good as it is right now. So the question will be, we still need to use CAR T in that setting.
Yeah, I think that's, the emergence of polatuzumab in frontline kind of closes the window of that bridging use of polatuzumab somewhat, right? I think that the argument that you make is really important about using CD19 targeting agents prior to CARs, and I think probably one of our responsibilities as clinical researchers is we need to define whether we can sequence. We've both published in this, right, with the Lonca study. Before CAR T, you can use Lonca, the responses are there, and you can lose Lonca after. My suspicions that the people who have used tafasitamab have seen it before and after CAR T. I think that as a community of people who do research in lymphoma, we need to define whether we can do these so we can decide whether we should be using these drugs before or not, and not just doing it on a theoretical basis. I think that kind of maintaining these things can do theoretical, it prevents us from using something that could really help the patient. I think our initial impression was that, sure, you actually can salvage people with CAR T after Lonca, and you can salvage people failing CAR T with Lonca, maybe with a TAFA-based combination that can be possible. So sequencing 19 agents is an opportunity, but we need to figure out who, what, where, right? I think that's very important.
Yeah, I think we need more data in this specific setting because it's a very important question. Maybe this agent can be used early on will not affect the efficacy of CAR T. So I think it's a very important question.
Yeah, I think that we probably may be affected quite a bit by the maybe more relevant data in ALL, where CD19 is a little bit more frequent, and I think that concern is there. But I think we probably should be answering it with data and know where, so that we can start considering these agents, because the landscape will change, as we've been kind of repeatedly saying. And I think the first change that we'll see is that we'll start discussing, well, can we use POLA in these early refractory patients for whom we previously used it for kind of bridging them to CARs. And I think that's the additional discussion is, should we be finding more effective regimens for that underserved group of people who have rapidly progressing disease? And I think that loss of the POLA use there will kind of force our hand to say we need to find something better. It's like POLA's not available anymore. It wasn't that robust to start with, and we can't just bend that like we did. So I think we already didn't. So what are we going to use for bridging people to CAR? I think, as a mode of conclusion, what do you think what is really exciting you in the horizon? We talked about bispecifics. What else is there that you're kind of interested in?
I think the combination of these agents. I think this agent, that all of these agents as single therapies have demonstrated important responses. I think with the combination, we will be able to encase, hopefully, that response. I think the challenge will be toxicities. So because it may be an overlap of toxicities, and some of these agents may not be so easy to combine with chemotherapy backbone. So maybe I think in the near future, we will be able to treat patients without chemotherapy backbones, but we still need to be sure. The problem, I think, we know that we can cure 60% of the patients with R-CHOP. So we want to make sure that we are able to keep in those patients will achieve remissions for a long time. So, but I think in the near future, hopefully, we will be able to cure many of these patients without chemotherapy.
And I think on that really optimistic note, we'll give Dr. Alderuccio the last word, and thank you very much.
Remember to receive your credit and evaluate this program. Please visit morningcommutepodcast.com/BCell3. Look for all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.